Hello, good evening everyone. Question number, Nimra is asking question number 49, right? Most common cause of unstable lie is, good evening Kavita, good evening Nimra. So, most common cause of unstable lie is, of course, multiparity. So, multiparity is responsible for almost all the malpresentations. Okay, multiparity is responsible for almost all the malpresentations except, can you tell me, except what? Multiparity is responsible for all the malpresentation. Nimra, can you tell me which? Multiparity is responsible for which malpresentation multiparity is not responsible? Can you tell me? Can you tell me, please? For occipital posterior, malposition, multiparity is not responsible. There, the occipital posterior is most common in occipital posterior is most common in occipital is in primigravida. When we compare primigravida, rest all malpositions and malpresentations are common in common in multi. Okay, is it clear, Nimra? Okay, Dr. Kavita, do you have any significant queries or you want to discuss me all? Please speak out. So this question is clear to you all. In transverse lie, the presentation is breech. So the presentation is shoulder. Why it is shoulder? Because in transverse lie, the fetus is transverse. So this shoulder is what is coming at the internal os. Okay, the fetus is like this. So shoulder is coming at the internal os. So that is why the presentation. What is the definition of presentation? What is the definition of presentation? So presentation is the part which is coming in the, yes, come on, the part which is coming in the part coming in the lower pole, the part coming in the lower pole of the uterus. Okay, is it okay? Very good, very good. And presenting part is the part which is coming in the what is presenting part? What is the definition of the presenting part? Presenting part is the part of the presentation which is coming at the internal os. Very good. The part of the presenting part of it which is coming at the internal os. Good. So that is it. So here the presentation is this. What is the incidence of the, very good, internal os? What is the incidence of the breech presentation? You have to tell me. In the breech presentation at term, why it is discussed here at term? We know that numbers are difficult to remember, but why we are discussing here, yes, it is 3%. But why we are discussing here number? What is the cause of the breech that we should know? When we are discussing, why not A? So in breech, what is Dr. Nimrat, in the morning you were having this confusion. Please listen here. Most common cause of breech. Most common cause of breech is prematurity. Okay, when we see at 28 weeks, do you know how much percentage it is breech? It is 30%. 30% of the pregnancies, they are breech. Okay, so prematurity is the most common cause. Now this we are done. What is the another most common cause? What are the other causes of breech? What are the other causes of breech? The other causes of breech are, can you tell me what are the other causes of breech? See, head is a heavy thing. Head should come down. Head is a heavy thing. Head should come down. So, placental anomaly, very good. Anything which is obstructing the head will cause breech. Congenital anomaly of the fetus, pelvis anomaly. Then what else? Yes, twins. Then twins. Then what else? Polyhydramnios, or you can say Liker anomalies. Liker anomalies. Poly or oligo, both of them are responsible. Very good. Very good. Dr. Iqbal, abruptio is not responsible, bete. Okay, pelvic tumors. So whatever stops the fetus to rotate, fetus को नीचे नहीं आने दे रहा है उसके heavy head को. Which congenital anomaly is mainly responsible for breech presentation? Nimra? Yes, multiparity, very good. Nimra, which congenital anomaly is responsible for breech? Will you tell me? Yes, uterus anomaly, septate. Which congenital anomaly is responsible for breech? Can you tell me? Come on, dear. Congenital anomaly of fetus. Which congenital anomaly of fetus? Hydrocephalus. Hydrocephalus. Hydrocephalus is responsible for causing breech presentation, because then, yes, very good, very good, good, very good. So that's all. That is what this was asking, that incidence of breech presentation is very less when the case goes up till term. True about frank breeches. I'm not having the question numbers today. Let me open the telegram. What was number 6 you specifically asked, no? Yeah. Nimra, question number, most commonly associated with true about frank breeches. True about frank breeches, that it is not most commonly associated with congenital anomaly. Nimra will tell me most commonly it is associated with. Come on, tell me. It is most commonly associated with what, dear? Now only we discussed. It is most commonly associated with what, dear? Prematurity. So this is false. We got the answer. Footling presentation. Most commonly it is associated. Frank breech. What is frank breech? There are 3 types of breech. Frank breech is the one in which the head is like this. The frank breech is the one in which the head is like this. This breech is above and the hip is flexed. The hip is flexed and the knees are extended. Frank, extended breech. Very good. So here there is no footling presentation. Okay, there is no footling presentation. There is no footling presentation in the it. So ECV done after 36 weeks is best. This is right. Has hip extended and knees flexed. This is again right. This is again wrong. Hips are flexed and knees are extended in it. Okay, there is circuit problem. Let's take the question number 7. Most common pelvis associated with direct occipital posterior is, can you tell me? Nimra, yes, hips are flexed and knees are extended. So you tell me. So this is wrong. Hips are flexed and knees is extended. So this is wrong. Yes, most common pelvis associated with direct occipito-posterior is anthropoid pelvis. Why it is so? Because in the direct occipito-posterior, what is happening? In the direct occipito-posterior, what is happening? What is direct occipito-posterior? In which the occiput is lying near the sacrum. In which the occiput is lying near the sacrum, and anthropoid is pelvis. What is the shape of the anthropoid pelvis? Be fast. What is the shape of the anthropoid pelvis? It is longitudinal oval. Longitudinal oval. So because the narrow walls are, you can say are near to each other, so the occiput goes into the broad part in the anthropoid pelvis. Very good, very good. Now next is most common cause of occipito-posterior position in the fetal head is, answer is android pelvis. Most common cause of occipito-posterior position is android pelvis. Why there is android pelvis? Here it is android pelvis because in the android pelvis, what is happening? Android pelvis is heart shaped and it is broad posteriorly. It is broad posteriorly, and occiput is also broad posteriorly. So broad occiput and broad posterior pelvis, they go together. This was revision, and in the last quiz also we did this. Broad posterior, in the android pelvis, the posterior part is broad, so the broad posterior part goes there. Okay, got it? Got it? Now let us see the other options. Maternal obesity. Obesity is responsible for malpresentations, other malpresentations. Multigravida, I told you, in occipito-posterior, there will be, it is common in primary. So it is exception. Occipito-posterior is common in primary. And deflexed head is a, very good, Nimra. Deflexed head is a, yes, come on, say deflexed head is a symptom, or you can say is a presentation of breech. Occipito-posterior diagnosis in labor management is, what is the management of occipito-posterior? Very commonly asked question, quite expected question in your exam. What is the presentation? What is the cause of occipito-posterior position in labor? What you will do? How you will manage it? No, never. Occipito-posterior position, if it is a gynecoid pelvis, then it will rotate and become occipito-anterior. There we have to do normal delivery, and then normal delivery will happen. There occurs occipito-posterior, beta. The diagnosis is occipito-posterior, dear. We are not going to do cesarean in occipito-posterior. Here I don't know the name. N is asking. Okay, N is texting. You will never do cesarean or ECV. What is the presentation in occipito-posterior? What is the presentation in occipito-posterior? N, please can you tell me N? What is the presentation in occipito-posterior? It is cephalic presentation. So no need of ECV and no need of exercise. And if the pelvis is android, what we will do in occipito-posterior? Beta, this you are telling me, and this you are telling me engaging diameter. I am asking you what is the presentation. Presentation is the part which is coming in the lower pole of the uterus. Okay, so the presentation is cephalic. Okay, so in the android pelvis, if in the occipito-posterior it is an android pelvis, so what we will do? We will come on everybody. In the android pelvis, we will apply the forceps, right? Because in the android pelvis, the front pelvis is the narrow pelvis. What will occur in the front pelvis? the rotation will not occur, because in the front pelvis, android pelvis is heart shaped. In the front pelvis, yes, Dr. Kavita, we will apply vacuum preferably, then forceps, because vacuum help us in rotation. Vacuum or forceps. Vacuum is preferably because there is deep transverse arrest in deep, and if it is a anthropoid pelvis, if it is an anthropoid pelvis, then backward rotation will occur. Backward rotation will occur, and what will happen? Phase 2 pubis delivery will occur. Okay. Occipital posterior, this management is very important. Please keep it on your tips, because gynecoid pelvis is the most common pelvis. So we will always do normal vaginal delivery. Okay. Okay. Will you remember? And will you remember? Okay. Chaliye, next. In case of direct occipital posterior, the most common cause of what is the most common complication in the direct occipital posterior? See, so in the direct occipital posterior, you all know Dr. Kavita, please explain your question. And in which, in right occipital posterior, there is rotation 3/8. Okay, in android pelvis, there is front rotation 1/8, and in the direct occipital posterior, yes, they can ask you, but they don't usually go in that detail. Rarely they can ask you. Okay, rarely they can ask you, but usually they don't go in that detail. These are not the common questions to be asked. Okay, now they are asking you what is the direct occipital posterior position complication. If the you all know, in the direct occipital posterior, phase 2 pubis delivery occurs, and what is its complication? Its complication is there a complete perineal tear. Let me tell you, if there is breech delivery, no, Nimra, listen carefully. If there is breech delivery, then there will be compression of the head. Okay, and then there will be tear of the various cerebral ligaments and all these things. Then there will be occurring intracranial hemorrhage. Intracranial hemorrhage. Okay, got it. When there is breech delivery, intracranial hemorrhage, and due to the tear, the another complication which is expected is cephalohematoma. But when there is phase 2 pubis delivery, now we are not in the question, it is asked phase 2 pubis, that is, first the face is coming. Usually first the occiput comes. So when such type of delivery is there, then a large diameter has to come out of the vulva. Large diameter has to come out of the vulva. So of course the perineal tear will occur. Is it okay? Why perineal tear occurs in phase 2 pubis delivery? Because when the face comes, then the head is in the deflex state. Okay, when occiput comes, the head is in the flex stage. When the when the occiput comes first, then the head is in the flex stage, and the lesser diameter comes out. But when the face comes, the larger diameter comes out. So vulva has to extend more, and complete perineal tear occurs. So what are the complications with the yeah beta Nimra, we are talking about the fetus only. See, in the mother, no intracranial. Okay, sorry, question is wrong, Nimra. Question is wrong. Complete perineal tear complication occurring to mother, it is. Question is wrong. I will correct it. question is wrong. I will correct it in the quiz. Okay. Next, a second gravida whose first baby is in the labor. Okay, now here it was a it is a occipital posterior and already 1 hour has passed. Already it is more than 1 hour. So what is the duration of the second stage for the, please tell me, what is the duration of the second stage for multigravida? To say it arrest. For primigravida, it is, tell me, come on, we should revise the numbers also. No. For the primigravida, beta, it is 1 hour is the normal time which the second stage takes. Okay, which the second stage takes is the 1 hour. But we will say it's slow progress if it is 2 hours. This is slow. The one we can say protracted. And if it is arrest, then it will be 3 hours. Okay, these are the figures. Very good, Mr. N. Very good. And in the multigravida, what are the duration? Please don't forget, these days large number of questions are being asked on this. It is 30 minutes. Okay, and double it. 1 hour is the duration for protracted and 2 hour is the duration for saying it arrest. Protracted is delay progress. Okay, delay progress. Okay, so here it is a multigravida and more than 1 hour. It means to say it arrest. In case of epidural, Nimra, you have to add 1 hour more. Okay, in case of epidural, you have to add 1 hour more. Okay, for the protracted, you are just doubling the time, and to say it arrest, you are just adding 1 more hour. Okay, you are just adding 1 more hour. Okay, and in multi also you are doing the same thing. It was 30 minutes and you did 1 hour, doubled it, and to say it arrest, you just add 1 hour. For epidural, you have to add the 1 hour more. So here it was more than 1 hour, means it has slowed, it has almost taken the double time, and now station is at +2 and right occipital posterior is there. So you know the reason, due to the occipital posterior, it has got prolonged, but it is not arrest. Mother is exhausted, means mother can't bear down no more. So the management will be vacuum. Why it is not vacuum? Why it is not forceps? Why it is vacuum? Because vacuum can only rotate. Vacuum can only rotate. Forceps cannot rotate. Do you got this thing? These type of questions are coming very frequently in your exams. Have you got it, Nimra? Okay. The interior fontanelle is easily felt in. So now you know that if this is the fetal head, then and here this is the fetal head. If this is a case of occiput posterior, okay, occiput posterior, then occiput will be lying here posterior, and here will be lying your anterior fontanelle, right? Here will be lying your interior fontanelle, because in interior fontanelle there are, so this is posterior sacrum and this is anterior your pubic symphysis. Okay, so now here what is happening, they are asking anterior fontanelle is easily felt. Whenever we do PV, what is easily felt is anterior interior things are easily felt. You see what is our direction of the PV? We are making our fingers like this to go. So we make our fingers to go anteriorly. That is why anterior fontanelle is easily felt. Okay, engaging diameter in occipital posterior position or deflexed head is. Okay, so anterior fontanelle is easily felt in occipital posterior. Have you got this thing? Okay, next is engaging diameter in occipital posterior or deflexed head is. You will see here carefully, whenever such a question are asked you, you make your head why not in face or brow? I don't understand you. Nimra, please write. Deflexed head is one of the finding in occipital posterior. It can also occur in other presentation. Okay, but in occipital posterior, one of the finding is deflexed head, right? And why not in face and brow? So face and brow, there are also these diameters, occipitofrontal, but question here is asked in occipital posterior. Okay, actually there were two questions asked previously, so I made it one, engaging diameter in deflexed head or occipital posterior. Nimra, is it clear to you? One of the finding, Mr. N, in occipital posterior is deflexed head, and for knowing which diameter is there in deflexed head, you keep your head deflexed and make a pelvis like this. Okay, you will see that you are touching behind occiput and here frontal, occipitofrontal. Okay, like this you can do, you will able to come. Yeah. Anterior fontanelle is not easily felt in brow or face. No, they are not felt. What we feel in brow, Nimra? What we feel in brow? Please tell me what we feel in brow. See, if this is the fetal head, no, I will tell you. If this is the fetal head, this part below the nose is face presentation. Okay, this is face presentation. And right, very good Iqbal, very good. In the brow presentation, this is felt, and anterior and posterior fontanelle are felt in vertex. What is, Nimra, what is vertex? Vertex is between anterior fontanelle and posterior fontanelle. Anterior fontanelle and posterior fontanelle. Vertex presentation is, what is the part of the, these are the three parts of the skull. Got it? So if it is a brow presentation, we will feel sinciput or forehead and supraorbital ridges. Supraorbital ridges and sinciput. Forehead. Sinciput, another name is forehead. And in the face presentation, what we will feel, Nimra? We will feel lips and nose. Got it? Got it? Let's go to the another question. Question number 14. Hand prolapse is seen in, come on now, write down fast, it is easy. Hands prolapse is seen in, very good. Hand prolapse is seen in active student. Transverse lie. Placenta delivery is done by which method? Come on. Placenta delivery is done by Brandt Andrews method. Brandt Andrews. The controlled co-attraction method is also known as Brandt Andrews method. Okay. Arms in breech are delivered by Lovset. See, we hug by arms. Okay, and love set, hugs by arm. Okay, love gets set when one hugs. Okay, love set is for extended arms, right? Do you all remember Shah Rukh Khan pose? Do you remember Shah Rukh Khan pose? Right? When Shah Rukh Khan extends his arm, then every love gets set. Okay? Okay. Deep transverse arrest is found in which pelvis? Come on, answer. Very good. Deep transverse arrest is found in which pelvis? Android pelvis. Then we have to apply forceps. Very good. Now here again android pelvis is there. So what is our answer? Multigravida, same question, but the pelvis is android. What we will do? Very good. What we will do here? Yes, come on. Stage is more than 1 hour. So it is a protracted second stage. Mother is exhausted. No. Mother is exhausted. Okay, so here we will do manual rotation, because here manual rotation, here we will do manual rotation, forceps or vacuum, anything. Why it is written forceps or vacuum? Because when we will do manual rotation, head will come like this. Okay, head will come like this. NVD is not possible in android pelvis, because android pelvis is heart shaped. NVD does not occur till occiput becomes anterior or occiput becomes posterior. Okay, vaginal delivery can occur as phase 2 pubis delivery, or it can occur as when occiput becomes anterior. So how come we are doing forceps in android? We are doing forceps in android because forceps can rotate up to 90 degree. Maximum 90 degree rotation can be done by forceps. Is it okay? Is it okay? Maximum 90 degree rotation can be done by, but not more than 90 degree. So when we will rotate this, so when we will do rotation, this occiput posterior, this arrow mark is for occiput. Okay, when we will rotate this, yeah, Nimra, listen here, I am telling your answer only. When we will rotate this occiput posterior will become transverse. Occiput transverse. Okay, occiput transverse. Now you can apply the forceps, because to make it occiput anterior, now angle is 90 degree only. Okay, so that is why it is written rotation plus forceps or vacuum. Is it clear? Is it clear, Nimra? Waiting for you. If rotation would not have been written, then the answer would be vacuum. Clear? Okay? Yeah, very good, very good, very good. Okay? Okay. Most common cause of breach. Come on, most common cause of breach. Prematurity. Is it clear? I think it was repeated question. 17. After coming head of breach has difficulty in all of the following except F. Now what is after coming head? Yeah, very good. Entrapped fetal head is seen in entrapped fetal head. Now when after coming head gets entrapped, gets stuck, it is known as entrapped fetal head. When it will get stuck, can you tell me? When the fetal head is large. When the fetal head is large, then it will not come out of the pelvis, right? So when the fetal head is large, it means it is either extended head, or it is hydrocephalus. Very good. Hydrocephalus, or it is macrosomia. Macrosomia. And also in incomplete dilatation of cervix. Same, in incomplete dilatation, the head would not come out. No role of placenta previa. Okay, no role of placenta previa. Next question is also the very same. Any problem? Clear to everyone? 17 and 18 questions were same. Okay, come on. Next question is, what are the reasons for decreased fundal height? Number one reason number one reason for decreased fundal height is, can you help me? Oligohydramnios, uteroplacental insufficiency, uteroplacental insufficiency. Third is transverse. Fourth, you can also say IUGR. Okay. Fourth is IUGR. Okay, got it? Very good. Very good. So transverse lie has decreased fundal height. This you have to keep in your mind. The other reason for decreased fundal height is oligohydramnios, uteroplacental insufficiency, transverse lie, and IUGR. Will you remember all these causes? These are very simple fundas. They can be asked you again and again. Okay. Persistent Occipital Posterior. This question was asked in persistent Occipital Posterior. It's not direct Occipital Posterior. It is persistent Occipital Posterior. Persistent Occipital Posterior is common in, can you tell me, in what all? Anthropoid. So no rotation. So no rotation in anthropoid pelvis possible. Okay, no rotation in manual rotation. No manual rotation in anthropoid pelvis possible. Okay, no manual rotation. Okay. Next is breech vaginal delivery false is, for breech, fetal heart rate monitoring done for mother. Yes, it is done for mother, fetal heart rate monitoring, because breech delivery is a risky delivery. Okay, breech delivery is a risky delivery. So no continuous fetal heart rate monitoring. Yes, the answer is B. Why it is B? You will listen me carefully. See, if the factors which will decide that the breech will deliver or not, are it's when the breech is in labor, then breech can deliver. Okay. Nimra, the answer is C for this. Breech identified for the first time during the delivery. Okay. So we usually deliver the breech in the delivery whenever the breech is in labor. So what all are the factors which decide that the breech can deliver or not? Number one is, yes, can you tell me what all are the factors? Number one is parity. Multigravida delivers easily. Okay, parity. These are combination of these factors we have to see. Not only one is responsible. If the patient is in labor, the breech will deliver easily. If the patient is in labor, the breech will deliver easily. Number 3 is, come on, tell me, number 3 is is parity, labor. Of course, in the labor it is dilatation and other factors, okay, and effacement, dilatation, fetal head, all those favorable direction. And number 3 is pelvis is adequate or not, right? Or and any absence of congenital anomaly, macrosomia is absent or not. So this next question is the question of NEET PG 2023. Transverse lie, yeah, this is correct. And then this is breach identified for first time in contra. No, it is not contraindicated. Labor is a favorable for breech delivery, and breech delivery is done in hospital where emergency cesarean facility is available. This is 101% right, because any time the fetal head can get entrapped and then we have to deliver the baby by cesarean. Done in presence of expert obstetrician. Yes, obstetrician should know all the maneuvers very fine manner. Okay. Next here is transverse lie at 36 weeks 6 days. Till the transverse lie is not in labor, the management of transverse lie is external cephalic version. Okay. Once the transverse lie has gone into the labor, the management is cesarean. Only there are two management. So transverse lie management before labor is external cephalic version, and the transverse lie management after the cesarean is after labor is cesarean. Okay, got it? Next is 35 years old multiparous present in, yeah. So what is the breach is? Yes, can you tell me? What is the complete breach? There are 3 types of breach mainly. See here. This is extended breach. Yeah, Nimra, it is always after 36 weeks. Why we do the ECV after 36 weeks? There are 2 reasons for it. Number 1 reason is that after 34 weeks, the AFI starts reducing. So head gets bit fixed. And after 36 weeks, there is little bit of engagement of the fetal head. So the reversion back is also not possible. Okay, it is not that once we will do ECV and then it will completely go back. Okay, so see, this type of breach is known as extended breach. Okay, this type of breach is known as extended breach. It depends on the knee joint. If knee joint is extended, it is extended breach. It is also known as incomplete breach. And what is its another name? The name by which examiner asks you question. What is that name? Can you tell me? Frank breach. Frank breach. Since this is the most common breach. So I would like to tell you to learn only these breach name. They are sufficient for you all to deliver. Okay, extended. So here what is happening, I will tell you. Ultrasound shows fetal head is in the fundus and fetal spine is parallel to mother spine. Knees and hips of the fetus is flexed. So if both are flexed, then it is complete breach. Okay, got it? So you have to learn all this name of these breach. The one in which knee is extended breach, incomplete frank breach, and it is the most common breach. Okay, let's go to the next question. The following are related to face presentation except, okay, the commonest position is left mento anterior. Always the anterior positions are most common than the posterior positions. Okay, in everywhere the anterior positions are most common than the posterior positions. Okay, got it? Next is engaging diameter is submentobrachmatic. That you know in face presentation, the engaging diameter is The diameter distending the vulval outlet is mento-vertical. No. Okay. Footling presentation. Okay, I will tell you. I think 2 questions are left. What is footling? I will tell you. Here what is happening, Dr. Kavita? Here what is happening in footling presentation? The joint is extended. Okay, hip joint is extended. The fetus has 2 hip joints. So any one of if hip joint is extended, then the presentation will be foot, isn't it? Got it clear? Got it clear? Dr. Kavita, got it clear? So when hip joint is extended, then the presenting part will be footling, foot, either one foot or both the feet. Okay, so in these case, one has to do cesarean. Okay, please take question number 24. Yeah. Okay, I will take question number 24. So I have to open it. Dr. Kavita, got it now? What is the relevance of footling presentation is that you have always to do the cesarean. Yeah, for the what are the methods for after coming head? So we have missed it, so I have come on that question. What are the methods for the delivery of the after coming head? Okay, so you should know that what are the methods for after coming head. Number 1 is, best method is Piper's forceps. No, Dr. Kavita, it is something very normal. It is something very normal to have in the breech vaginal delivery. It is not entrapped. Okay. They have not used the word entrapped. Okay. They have not used the word entrapped. They have used after coming head, and it is in the case of the normal breech delivery, assisted breech delivery. So for the after coming head, the method is best is Piper's forceps. The forceps which has a long shaft. Okay, got it, Nimra? Number 2 is Mauritius Smiley White technique. What we do in this method is we give the shoulder traction and malar flexion. Malar is these bones. Okay, malar is these bone. So what is this is shoulder traction. One hand is on the shoulder and the another hand is on the malar cheekbones. Malar flexion. Got it? Have you got it? Have you got it? Very good. Malar flexion and shoulder traction. So that is, and number 3 is Marshall-Burn method. So what is Marshall-Burn method? It is to make the C, to rotate the fetus in a C-shaped manner. That's all. Okay, that's all. So the answer to this question is, you can see in the coming diagrams there was a pic of Mauritius Smiley White technique. Okay, have you seen that pic? So best is Piper's forceps. There are 3 procedures for the after coming head of the fetus. Number 1 is Piper's forceps. Number 2 is Mauritius Smiley White technique, in which we give shoulder traction and malar flexion, and the another is Marshall-Burn method, in which we rotate the fetus in a C-shaped arc. Okay, in which we rotate the fetus in a C-shaped arc. So number 2 method is, which is best, is Mauritius Smiley White technique. So multigravida with previous to normal delivery, unstable lie. What is the most common cause? If the lie is unstable in the multigravida, so the reason is placenta previa. Why it is? Okay, let me tell you about the forceps. I think there is some confusion. Wrigley's forceps are applied at station +2. Okay, at station +2. Wrigley's forceps are applied at station +2 in vertex presentation. Okay, in vertex presentation. Okay, Keelan's forceps are actually used for rotating the fetus head. Okay, for rotating the fetus head, but they also have very long shaft, so even we can use sometime in the case of breech. Is it clear, Nimra? Is it clear? Nimra, is it clear? Wrigley's forceps have a small shaft. What is shaft? This straight, ये द जो सीधा सा होता है ना, स्ट्रेट सा पार्ट होता है फोर्सेप के अंदर, ठीक है, दैट इज नोन एज ओके. अब रिग्लीज फोर्सेप में ये बहुत छोटा होता है क्योंकि ये स्टेशन के लिए, स्टेशन +2 के लिए बना होता है. ओके, better, Wrigley's forceps is wrong. The question was, Nimra, all the forceps can be used except, all the methods or all the forceps can be used except. So there is Wrigley's forceps. Okay, best forceps is Piper's forceps. Is it clear? Best forceps is Piper's forceps. Okay, Keelan's forceps is a rotational forceps. Only you have to learn these three names in forceps. Okay, only you have to learn these three names. Wrigley's forceps has a short shaft. Keelan's forceps is for rotation but has a long shaft. And Piper's has a long shaft and it is for breech. Clear? Okay. So the cause for the unstable lie in multigravida is placenta previa. The most common cause is placenta previa, because you all know that placenta previa is associated with multiparity and elderly gravida. We will learn this, the risk factor, elderly gravida. Got it? Got it? Okay. So this we have discussed beforehand only. The commonest position is left mento-interior, because always the interior positions are most common than the posterior positions, right? And the submentobrachmatic is the engaging diameter. This I always tell you. Okay, let me see that in question number 44. We will be just doing it very fast, Nimra, don't worry. Engaging diameter is submentobrachmatic. This I always tell you, make your head like it is a face presentation like this and make a pelvis around it. So you will come to know that it is submentobrachmatic. Okay, it is submentobrachmatic. Vulval outlet is mento-vertical. This is wrong. There is elongation of occipitofrontal. This is right. Okay, there is elongation of occipitofrontal. This is right. Okay. Uh, this has been discussed that in the mento posterior, next question 27, mento posterior, there is no chance of vaginal delivery. We have discussed it in very detail. Okay, next 28th number question is that when external cephalic version we are doing, there are chances of chord compression. ठीक है, in ECV there are chances of chord compression, and when chord compression will occur, then there will be bradycardia. What you have to do, then you have to wait for 10 minutes. Wait for 10 minutes. If it gets solved, it is well and good. If it does not get solved, then what you have to do is, if it does not get solved, then you have to do it reversion. You have to do reversion. Okay. Transverse lie in labor, already told you. Okay. Next question is transverse lie in labor. Already told you, dear friends, transverse lie in labor. The answer is yes. Tell me. Those of you who are watching, transverse lie in labor. Always in labor, the transverse lie has got the management of cesarean. What is the clinical presentation of breech? What are the PA findings? Can you tell me? In breech, what is the clinical finding? PA finding. What do you get at fundal grip? Round, small, solid, palatable, and in the pelvis it is soft part is felt. Okay, again the most common cause is very good, round and small. Dr. Kavita, you will also remember this thing. Okay, now 31 is, if it is a non-engaged breech at term, you are definitely going to do cesarean. Okay, because if you are going to induce, it is not. 32 number question, it is Piper's forceps, right? It is Piper's forceps. This is Piper's forceps because it has a long shaft. Okay, got it? Next is, this is extended breech. What are the another name? Let's revise it. Frank incomplete. Have I left 31? Beta, Nimra, it is not engaged. When head is not engaged, it is always LSCS. Yeah, head is not engaged at term. Head is not engaged at term. Okay, either you have to do ECV or you have to do LSCS. But since here no ECV was given, so we have to choose LSCS. Normal delivery is not possible. Okay? Is it okay? It is difficult in the breech if it is not engaged. So then this breech is flexed breech because knee joints are flexed. Got this in? LSCS in breech is must in. Can you tell me in which all condition? Foot link. Dr. Kavita, tell me foot link. Next is extended head. It is also known as star gazing sign. Hyperextended head. And number 3 is big baby. macrosomia. Okay, next is, in all these cases of breech, LSCS is done except flex breech, we have done it. Best method to deliver extended arm is love set method. ठीक है, love set in hug. Chord prolapse in breech is common in breech is common in, yes, footling. Why it is common in footling? Can you tell me? Because in footling, the knee joint is extended. Because hip joint is extended. So this cord can easily come down. In all these cases where hip joint is flexed, the cord will come here, so it will not let the cord to come down. Okay, got it? Got it? Very good. Perinatal mortality in breech is due to, we already explained you this, it is due to intracranial hemorrhage and, or, come on, tell me, or cephalohematoma. Got it? Not a method of breech is, of course, Ritson maneuver. Ritson maneuver is for, yes, can you tell me? Ritson maneuver is for delivering the head in second stage. Okay, delivering the head in second stage. That is for what it is, the Ritson maneuver. Got it? Very good. Best method to deliver fetal head is Piper's forceps. Okay. Malar flexion, here is the picture. Malar flexion and shoulder traction. You can see this is the second method, and here it is Mauritius Smiley White technique. Okay, it is Mauritius Smiley White technique. Okay, malar flexion and shoulder traction. Okay, so you can remember this name by S stand for smile. So when you are flexing someone's cheeks bone, of course that baby will smile. Okay, smile is malar flexion. Okay, subumbilical flattening is seen in the case of, can you tell me? Subumbilical flattening is seen in the case of, if this is the case of Occipital Posterior. Yes. If this is the case of Occipital Posterior, occiput is posterior and this is mother abdomen, because here sinciput is there, limbs is there, so there is subumbilical flattening, because here a sinciput and limbs are there. Okay, very good, very good. OP with anthropoid pelvis. OP with anthropoid pelvis is, yes, phase 2 pubis delivery. Got it? Phase 2 pubis delivery. Right? Any problem in this question? Question number 43. Question number 44. Incidence of OP of all vertex is 10%. Need not to learn. Need not to learn. Okay? You just learn the breech presentation. breech presentation. Okay. Mento-vertical is the diameter in. Can you tell me? Mento-vertical is the diameter in. Mento-vertical is the diameter in brow. Very good. Largest diameter. Best management of persistent mento-posterior is, can you tell me? Mento-posterior. This we did it. The face has two presentation, mento-anterior and mento-posterior. Mento-anterior management is NVD. That I told you, man. And mento-posterior is LSCS. 47. Repeated transverse lie is. Repeated transverse lie is. Yes. Repeated transverse lie is. Repeated transverse lie is seen in subseptate. Why is septate not here? Why is septate not here? And why is subseptate? Why subseptate? Why not septate? Because subseptate is more common than septate. Okay? Yeah. What is the difference between subseptate? Septate is that is fully dividing the uterus. And subseptate is which is partially dividing. Okay? Okay, subseptate is more common. Okay, and which is the uterus in which there is transverse lie. This was a question of NEET PG 2021. Transverse lie is not possible in which uterus? Same options were there. Tell me. Uterus didelphus. Why? Because in uterus didelphus there are two uteruses. The uterus becomes more longitudinal. Okay? Uterus becomes more longitudinal. That's why. Okay? Okay, so the answer is uterus didelphus because uterus becomes more longitudinal. So that is also the reason that in septate uterus, in full septate uterus, there will be again not transverse lie. In septate uterus, there will be not transverse lie. There will be in the subseptate uterus. The uterus which is like this. Okay, so this part is small, so head will lodge here. Okay, this part is small, so head will lodge here. Got it? That is why it is subseptate. Got it? Got it? What is? This is subseptate. Okay. Last question. In multipara, is it justifiable to wait for normal delivery in transverse lie? Please tell me. Hand prolapse is not associated with breech. Hand prolapse is associated with transverse lie in labor. Hand prolapse is not associated with breech. Hand prolapse is associated with transverse lie in labor. Okay? In transverse lie, you have to rule out chord prolapse because it is very near, right? And always anterior positions are common. Mento anterior, dorso anterior, all these positions are very common. Thank you for being with me. Okay, see you tomorrow in the next quiz. Please practice questions, your wrong questions. It's not only you have to practice one time, you have to practice it again and again. Do like, share and comment on my channel. It will help me a lot in my teaching journey. Thank you for being patient and listening me. Bye bye.